Does that improve the confusion? Does that improve his mental state? Because if it doesn't, then we need to be looking for other things. Okay? So again, breathing. Rate quality character, rate rhythm and depth. Trying to think, there was another word that goes with there. I think there was 4 of them that they listed in your book. Now, it is very important to bring, if you have one, a stethoscope that you're going to be using throughout the semester. So kind of work with us here, okay? Once you get your stethoscope, you are going to be listening on each other, and then you're going to take them home, and you're going to listen on your spouse, your boyfriend, girlfriend, your kids, your dog, whatever, okay? In order to train your ears now for what you should be listening for, which is what normal sounds like. Because the moment that you hear something abnormal, you're going to know it. But you got to know what normal sounds like first. So when you get your stethoscope, you need to listen to yourself breathe, and then you need to start listening to other people. And if you got grandparents that's got maybe asthma or COPD or something like that, then take a listen to them so that you understand what you're listening to is not normal. Okay, they'll have a lot of sounds going on in there. Just like with heartbeats, you need to listen to your own heartbeat. Because if you don't train your ears now in a nice quiet environment, you're not going to be able to know what you're listening for when you're in the back of that ambulance going 65 miles an hour up the interstate with sirens going. And if you plan on being in the medical field for a long period of time, I strongly suggest that you invest in a nice stethoscope. That makes all the difference in the world. They even got, an electronic one that kind of amplifies everything at the bell. I mean, they're great, but again, if that's something that you need because you're hard of hearing or something like that, then you need to invest in one. Don't get one of the cheapies like the ones hanging back there, because those are the student ones, and I'm sorry I was not in charge of buying those because that's not what I would have chosen, but that's what was chosen, that's what we have to work with. So that's how come I'm encouraging you to invest in a good stethoscope so that you can start listening. Because again, when we listen to a patient, there's 12 to 14 different areas we're going to listen to. Several of them will be mid-clavicular. Some will be mid-axillary. And then the rest of them are going to be on the back. And again, you have to train your mind. A lung is 3-dimensional. If I only listen to the anterior lobes, I'm really not going to know what's going on in the posterior lobes. Or there may be something on the anterior lobes that continue on in the posterior lobes, and we need to know that. You've got to take the time to listen to their lungs because, again, it is 3-dimensional. The right one has 3 lobes, the other one has 2. And when we listen, we need to ensure that they are bilateral. What do I mean by bilateral?
Both sides.
Both sides. So if this sign sounds one way, then the opposite side should sound the same, correct? If not, then I have a problem. So when we listen, it's not a matter of, okay, I'm going to check the right first. It's a matter of, I've got to go from one side to the same side on the opposite side. This is how I know if they're bilateral. Okay? So mid-clavicular line, very important line. Mid-axillary line, very important because now we're listening to the sides of the lungs. Then we're going to go posterior and we're going to listen to the backside. And again, if you've ever paid attention to how your doctor, when you go to a doctor's visit, checks your lungs, she goes from one side to the same side on the opposite side. And then she'll kind of drop down a little bit, and then she'll go here. Okay, and this is how we do it, is like in an S shape all the way down, okay, when we're listening to lung sounds. This is important because not only are we listening when they inhale, we are also listening as they exhale. When we were talking about different lung sounds, right? We had the larynx here. This was the cutoff for the upper airway. And then the larynx, anything down that was the lower airway, right? So in the lower airway sounds that we're listening for wheezing, And again, wheezing can be both inspiratory and expiratory. We have crackles or rails, they kind of go hand in hand, and then we have bronchi. Okay, these are the sounds that we're listening for, and then normal, which is, clear lung sounds is what we're listening for. These are some of the lung sounds that we're listening for in the lower airways. This is caused by a different disease process as this. This is caused by asthma. This is caused by congestive heart failure.
And cigarettes.
I'm going to squeeze right here.
Right up
Okay, I love this poster. Okay, so just for a little bit of time right here. Okay, this is great. I took this poster from a pulmonologist who we were involved with doing a healthcare fair down in Calhoun County, which is one of the poorest counties in Georgia. And I love this so much, I begged and pleaded for the poster that I showed y'all, because it's a great example of what happens and what goes on during an asthma attack. So if you can look, okay, great trachea, man.
Yeah,
It's
that
just
looks
awesome.
good.
Okay, so the branches, the carina is the branch point, and then you have the right main bronchus, the left main bronchus, and then it kind of goes out into the tree formation, and then, okay, so what happens in asthma, when there's an allergen that triggers the asthma attack, okay, bronchoconstriction begins, which means both internal and external inflammation begins, okay? So your lungs and the alveoli have got these bands of muscle around it all the way down the tube. Again, this allows for elasticity to both stretch and constrict when needed. So you have constriction, and then you have an inflammation within the tube, because within the tube you have smooth muscle that's there as well. Inside the tracheal tube and bronchi and bronchioles is smooth muscle. So when that gets inflamed, it gets pissed off, it begins to swell. Then you have bronchoconstriction from the actual musculature on the outside, and then you have that trapped mucus that's within the center, and then you have excessive mucus that's trapped and can't get out. When you hear wheezing, it's the airflow that's going over the mucus, if you will, in that small little portion of an airway he now has. This is what happens in asthma. Again, wheezing can occur either on inspiration, on expiration, or both. And then we have something that's called the silent chest, which ain't good when you don't hear breath sounds on an asthma patient. Okay? Understand the process so you understand why you do what you do in order to treat him. This is very, very different than what happens within congestive heart failure. Remember that in congestive heart failure, if you recall the blood flow through the heart, what side is backing up into the lungs, the right or the left side?
Yeah, left side.
Left side, right? So if I have regurgitation backwards back into the lungs, right, lungs. I know, right? Wrong wave. Woo, okay, so here's the lungs, okay. And you have backflow in the lungs, then all of the alveoli are now filled with extra fluid. This is what causes your crackles and your rail sounds, because there's extra fluid within the alveoli that can't get up, and basically it's popping in there. How many of y'all eat Rice Krispies? Okay, when you put them in your mouth, they go, okay? How about Pop Rocks?
Yeah.
Pop Rocks. Okay, that's what that is, okay? So when you have backward regurgitation, the alveoli become filled with fluid. So now your alveoli is filled with all this fluid, and there's not a whole lot of gas exchange behind the alveoli. So with CPAP, this is where CPAP is like cash money, okay? When you connect someone to CPAP and it forces air at a continuous pressure all the time while you got that patient, so basically if this is the alveoli with extra fluid in it, CPAP is actually going to blow up the alveoli a little bit to where now you see that this amount of fluid is now here, which opens up for more surface area for gas exchange to occur. That's the purpose behind CPAP. It's a continuous flow of air to kind of blow up the alveoli a little bit so that greater surface area can happen for gas exchange. If not, your patient who's like this is not getting a whole lot of gas exchange, and they're going to, I'm not trying to be ugly, they're drowning from the inside out. That's basically what's happening. So one of the ways we can fix that is CPAP in order to help with the gas exchange process. Anybody got any questions? You cool? Okay. So, your book also, let me just kind of run through it. So it goes into some. Okay, so then it talks about mouth-to-mask and mouth-to-mask. So mouth-to-mask ventilations we did with the BVM, and then the rest of the chapters the BVM, one technique, and so forth. So one of the other things that it talks about is common causes of respiratory distress, respiratory failure, and respiratory arrest. Has everybody got this, or whoever's taking notes is going to pass it along?
Oh, that's my bad.
At this point in the class, when we drop this one.
I really don't like Mr. Ratio. Okay, so when we talk about, there's several different phases to respiratory distress. Respiratory distress being the first, in which the body goes into a compensatory mechanism in order to restore homeostasis. Okay, now, part of the reason why people can go into respiratory distress can be several things. One is pH of the blood, in which the pH is outside of the norm. That norm for pH is 7.35 to 7.45. Okay, this is the pH range that the body likes to work in. Very precise, very narrow. So if there's a decrease or an increase in the pH, then the body kicks into a compensatory mechanism in which it will either increase your respiratory rate or decrease it depending on where we're at. Another reason why someone can go into respiratory distress is, let's say they have asthma and there's been a trigger, and so now he's having respiratory distress because of the bronchoconstriction that's occurring and the fact that there's inflammation within the tubes and there's extra mucus. When someone goes into respiratory distress, that is the normal expectation that you would see. You would see an increase in respiratory rate. And I told you in anatomy and physiology that if you increase the respiratory system, what's going to happen to the cardiovascular system?
Everything increases.
Up. Okay.
Heart rate increases, blood pressure.
Okay. So cardiovascular system and the respiratory system work hand in hand. One increases, the other one will soon follow. If one drops, guess what? The other one will soon follow. Okay. You need to understand that, because once we start going into respiratory failure, that means that the body cannot compensate for the oxygen demands of the body as a whole. So yeah, we're marathon runners, okay? We're going to be in respiratory distress for a while, okay? We're going to be trucking along, and then once we come to the point where we can't do it no more because we're tired and the body can't keep up with the oxygen demands, guess what? Things are going to start decreasing. That's when you know that you're in respiratory failure, and soon after that, respiratory arrest and cardiac arrest is going to soon follow. Okay, you need to understand the process between respiratory distress, Okay, what you would normally see here, increased respiratory rate, increased tidal volume, increased heart rate, increased blood pressure, and then as we progress, because we haven't fixed it, then we'll go into respiratory distress and then respiratory failure. Okay, heart rate increases, respiratory rate increases, we'll do this for a while. Then as we begin to fail as a whole, then heart rate, respiratory rate is going to decrease, and then if we still don't fix that, then they're going to go into arrest, which means a cessation of breathing. And at that point, you're going to be breathing for them with a BVN, doing CPR. So that's kind of what your book goes into.
Cardiac arrest, right?
Cardiac and respiratory arrest, okay? Can't have one without the other. All right? So this is kind of the last portion of the airway management, artificial ventilation and oxygenation for you. I want you to review the numbers for the respiratory rate and heart rate that the respiratory rate that your book has on pediatrics as well as infants. Now that is something that you do not have to know for a test, but I want you to be familiar. Okay, so if I say I got an infant who's breathing 20 times a minute, you're gonna know that that's like way off, okay?
That should
be like
low.
40 to 60,
Yeah.
okay, for an infant. So, okay, I want you to know a range, be familiar, infant to children, because it is slightly different, because we're gonna go more into detail about that during chapter 9, I think, or whatever it is on lifespan development, okay? So kind of be familiar, but definitely know the range of 12 to 20 breaths per minute, however way you want to do that, okay?
One adult.
Okay. A little bit of anatomy terms, okay? These are opposites,
Slow and fast.
Mhm.
slow and fast, okay? You will see this on many things, including when we talk about respiratory rate, when we talk about cardiac rate, okay, or heart rate. So here's a couple of things, okay? So eupnea, and again, if you pay attention to if you pay attention to this right here, this has to do with breathing. Okay? This is a suffix, which means normal. So normal breathing would be eupnea. Slow breathing would be bradypnea. Okay? And again, this right here, breathing. And then tachypnea would be fast breathing. Okay? A couple of medical terms you'll need to know, because I see that they're using that in your book already. So, we're talking about breathing. So if we were to talk about heart rate, bradycardia is a slow heart rate, and again, this has to do with heart rate. And then tachycardia would be a fast heart rate. It's all a matter of just kind of putting root words, this being a root word.
It's combining form.
Yes. The O, the I, whatever. Okay, so
A,
for those of you that have taken
Don't like that
medical
root,
term, I love teaching that class. That was awesome. We had a lot of fun. Okay, so a couple of medical terms you'll need to know that you'll be reading about.
Yeah, I was looking for root in the book. And it's
Yeah,
combined.
they don't like using that at all.
It says
It's just
combining
a-
form, it doesn't
yeah.
use root.
It doesn't use root word. Yeah, no, that's how I teach normally. Root words with a prefix and a suffix. Yeah.
It's combining form.
Yep.
Yeah, I know, we were there on that.
Okay. So, anybody have any questions on this?
Nope.
All right. So that's our today. We have a couple of hours for this afternoon for those that would like to stay. I'm not saying that you have to stay, but for those that would like to stay, kind of go over equipment, go over concepts you may not have understood or whatever, that's what this afternoon session is gonna be for. So for those of you that need help, that wanna stay, you're more than welcome to stay. If not, you are free to go for the afternoon.